wherever you like after that.
Okay. Well, in my practice, most people who have an ankle arthroscopy have one of three problems. They either have impingement, an osteochondral lesion, or they've got a loose body. And impingement, I think we've talked about this one before, but you can break impingement down into soft tissue impingement, whether that's scarring, hypertrophied anterior syndesmosis ligament at the front of the ankle, called the AITFL, of course. Or it can be bony, and that's usually spurs. They can be coming off the front of the tibia, but they can also be in the anteromedial ankle, and they often are the kissing lesions that you see coming off both the talus and the tibia in kicking athletes particularly, and they get anteromedial pain. And you can have loose bodies floating in there around as well. Now, I'll just go to these. We'll start with impingement. That's probably the easiest thing to do. So you can see this one. You can see here that there's some spurring at the front of that ankle joint. Can you see my cursor moving?
Yep.
Yes.
Yep.
Good. And if I'm just going to minimize that one. Good. And again, if we look at the front of the ankle, it looks pretty normal. If you look very carefully, there's a bit of sort of narrowing in that little corner there because some spurs are coming together. Similar sort of thing occurring laterally, but there's no arthritis in that ankle basically. And MR, you can see here, spur on the tibia and a spur on the talus. You can imagine that in dorsiflexion, those two things are going to bump into each other. And again, different MRIs. There's a not fat suppressed proton density. Again, you can see that spur on the tibia. And same scan again, showing what we saw before, big spurs. You get better definition of bone anatomy on the PDs without fat suppression, in other words, the white ones, and you get more edema and pathology on the PD with fat suppressions. That's where the bone's black, i.e. that one. So in this case, I actually put the telescope into the guy's ankle, and I'll show you this one. Okay, so at the top here, this is tibia, and this big thing coming up to bump into him, that's the talar neck. So you can imagine that in dorsiflexion, that's going to be causing pain. You can get synovitis trapped between those two bones, and it's pretty obvious what's going on there. Does that make sense?
Yep.
Yep.
Okay, so that's bony anteromedial ankle impingement. Classic sort of situation. Let's get out of that picture. This is another one where you can see again, this is the tibia again, and this is again the talus coming up to meet it. And you can imagine that any inflammation or synovitis or synovium that's caught between them is going to become synovitic and painful. You guys still there?
Yeah.
Yeah, good. I'm just getting my screen back up again. Here we go. You can also just get isolated spurs. So this is just a really big spur coming off the front of the tibia. And the aim of all these sort of treatments is after surgery. So that one I showed you at the start with it moving, this is after I've used the arthroscope and the burr, and you can actually see that I've removed here and we've removed the talar bit, and that's in maximum dorsiflexion. So you can't see the articular surface, it's somewhere up under the ankle joint, but what was previously impinging on that video is now has now settled itself down. So that's quite a good way of treating that sort of condition. Have you got any questions about that one particularly?
Ben, after you've done that, how long would it take, say, a footy player to get back to sport in terms of return to sport?
That's a really interesting point. Even though it's done through two little arthroscopy portals, that is a reasonable amount of bone that you're taking out, and they are going to get a hemarthrosis. So I manage their swelling pretty aggressively with compression and rest for the first at least week. It's important to move them, but you don't want them to get too bleedy into the ankle, otherwise they just get really stiff and swollen. I think it's probably about 4 weeks before they're really getting back to activities. But it depends how hard they want to push themselves. They're not going to break anything by using it. They just might get a bit sore and swollen.
Right.
So
Okay.
leading on from that, Ben, if you were putting together a timeline, you would say first 2 weeks, kind of just weight bearers tolerated, let the wounds heal.
Yeah, so it depends how aggressive you want to push someone. It could be just a week. But 1 to 2 weeks of sort of letting the ankle settle. There's, as I said, rest, ice, compression, elevation, range of motion. After about a week, if their ankle's settled, they can get on the bike, and depends on what sort of dressings they technically get into the pool. But again, you don't want to be cutting corners and getting infected portals. But sometimes we do that, and getting them back to light sort of jogging, I guess, is going to be probably around the 3-week mark, depending on comfort, and then they progress after that. Okay. Again, just so I've covered it, this is another bit of loose bone in the actual front of someone's ankle. You can imagine that's a bit annoying. These are the people that often present with either locking or they have instability, what they think is instability, but when you actually examine them, they do not have ankle laxity. So this is sort of like a functional type of instability. It's not due to perineal tendons, but this is because every now and again they get a bit of bone jammed in the front of their ankle, and it makes them feel like they're going to roll their ankle. And obviously getting that out is quite a good thing. Sometimes if they're very big, you need to make a cut to actually remove it, because it's bigger than you can get out to an arthroscopy portal, but that's usually not such a big deal. Now, what else we got here? Okay, so as I said, ankle impingement and loose bodies is certainly very, very common. It's well treated by arthroscopy. If it's just a synovial band, that also can be removed. Here's some adhesions inside someone's ankle from a case I did last week. So the talus is the white thing underneath it, and this big sort of blob sitting here is actually an adhesion band that's going all the way from one side of the ankle joint across the front of the ankle joint. You can see the ankle joint behind, keeping on going across the ankle joint with lots of little bands in it. And that's simple to remove. Okay, so that's the equivalent picture to the first one there. And you can see my telescope, my chondrotome in there. And that's very simple to just remove that. And you can imagine that getting that out of that person's ankle is going to make a huge difference to how their ankle moves and feels. They don't have to be quite so complex. That's a much smaller one that's going out. That shaver in the top corner is a 3 millimeter diameter shaver. So you can see sort of the size. So that's a little teeny weeny one there. That one is well thicker than the shaver. So that's a pretty serious adhesion band. They usually occur after someone's had a hemarthrosis, bleed into the ankle following a sprain or something similar. And for whatever reason, they develop these adhesion bands. Not that difficult to diagnose on MRI. If I go back to that MRI that we saw before, I'll just pull up an MRI. Okay, I'll go 2 further, that one. So on the PD with fat suppression, i.e. the one we're looking at the moment with the black bone and the white water, what you see in these people is a black blob sitting in the front of their anterior ankle fluid. And as you slice or continue through the slices backwards and forwards, it's still there. So it's not like it's a discrete round thing like a loose body. It's actually a band that's going from one side of the ankle to the other. And that's pretty simple to see. those aren't likely to get better with a cortisone injection because there's no inflammation associated with them. If there's synovitis, it might help settle it. But something that's as mature as that is not going to disappear with a cortisone. However, if they have this, which is someone with a very synovitic inflamed ankle, you can see the ankle joints up in here, chondral surfaces, and clearly this is all very inflamed. That's definitely going to do well with a cortisone potentially. But again, if it doesn't settle down, then cleaning it out with the arthroscope is a very good option. Why might they have synovitis? Well, it can be post-traumatic. It can also be because they've got an underlying inflammatory arthritis or a crystal arthropathy like gout or pseudo-gout. You can see on this one, these little white specks floating around in this person's synovium. That's all little crystals of gout. And again, that's a systemic disease. It needs medical management, fluids and the rest of it, allopurinol or whatever. But certainly surgically, you can improve their symptoms by reducing their load of synovitis in the ankle. You just need to be a bit careful that you don't cause a flare of their inflammatory arthritis when you actually irritate the joint, because it can liberate crystals into the actual fluid and actually give them an acute episode of gout. So I usually put them on some anti-inflammatories at the time. Questions or anything at this stage?
Yeah, Ben, with the adhesions, so broken record here, but because you're not doing an osseous debridement, is there, again, return to sport? Once your portals have healed, you'll be able to get them going pretty quickly. Would they return in under a month if they...
I think that person is highly likely to be back doing everything by 3 weeks.
Right.
Because you're taking out something that is avascular. You are not going to get a hemarthrosis unless you hit something with your telescope. And yeah, they're going to do much better than the one that has a big bony debridement.
Yep. Makes sense.
It's quite nice to see a case like that because you just know you're going to go in there and just fix them. It's actually quite satisfying. Other things, just to go back to basics. For those who've never seen an ankle arthroscopy, those are the standard 2 portals. This is the lateral side of the ankle, the fibula. Its patients had a lateral ligament reconstruction at the same time. But there's 2 little portals here over the anterior medial and anterior lateral ankle. There are other portals that can be used. And this is me doing an arthroscopy. So again, anterior medial, anterior lateral. Now there's nerves that run down here and through here. It's got to be cautious of those. For those of you who have seen an ankle arthroscopy, you may have been in an operating theatre where the person's been put on distraction. There is a role for that. I tend to do it slightly differently to that sort of thing where the ankle's sort of fixed to the bed. But if you want to get through the ankle to an osteochondral injury at the back of the ankle, then this is what you have to do. For those who've seen me do it, I tend to do this, where I actually strap the ankle here, but I have a strap around my waist so I can pull back myself and distract the ankle. But if I don't want it distracted, I just can lean in and do this arthroscopy without distraction. A normal ankle, just to let you know, just like a knee, it's beautiful cartilage. That's the syndesmosis at the back here. Here's tibia at the top, and here's the talus. So that's what it should look like as a background to what we saw before. And again, from an anatomy point of view, not that important. But again, you're looking in. It's not that far from the skin to the inside of the ankle at the front. I can do an arthroscopy to the back of the ankle. And if you think about how far it is from the back of the Achilles into the back of the ankle, it's about 5 centimeters. So that's a much deeper arthroscopy than going in the front of the ankle, which is only about 1.5 centimeters. Moving on from that one, The other thing we were talking about was osteochondral lesions. How common are osteochondral lesions after an ankle sprain, Karthik? A bad ankle sprain?
Maybe 20%.
No, sorry, too high. You're the surgeon's friend. No, it's reported to be between 4 and 5% of severe ankle sprains have a significant osteochondral injury, which is one of the reasons why in someone who has recurrent sprains due to a very unstable ankle, you might want to consider stabilizing their ankle, either bracing or surgically, because they have a 1 in 20 chance every time they sprain their ankle of giving themselves a serious osteochondral lesion. And those are the things that can lead to long-term problems, obviously, with ankle cartilage and potentially arthritis.
Mm-hmm.
There are two main locations. One is on the lateral side of the talus, and that's when you invert your ankle. You can imagine the lateral side of the talus smashing into the lateral malleolus as the ankle inverts. And the other one is posteromedial. And some of those are traumatic. When the ankle inverts, the top of the talus sort of hits the back of the tibia. But there are also people who are born with chronic osteochondral lesions of their posteromedial talus. They look huge on imaging, but there's often a lot of edema under them on the MRI. In other words, they've been there chronically. I saw one of the Norwood footy team's female players relatively recently who had a bad ankle sprain, and as part of her workup had MR, which showed an acute anterolateral osteochondral injury, but a huge posteromedial osteochondral lesion, but it was undisplaced and there was absolutely no edema underneath it. So that's not new, that's old. And the reason that's relevant is that if something's old, you can usually leave it alone. You just need to know that these things can exist and been there for years. You don't just start sending them off to a surgeon. You might still want to do that, but they may or may not actually need surgery because it's a chronic issue. Some osteochondral lesions can heal very well by themselves. They become problematic if the overlying cartilage becomes loose and allows articular fluid to go underneath the osteochondral lesion, and that can cause edema in the talus. That's usually what causes pain, and sometimes that process can lead to little cysts forming underneath the talus because of fluid being pumped in repeatedly over years. And the other thing they can do is they can become unstable and either catch in the ankle or actually come loose and float around the ankle. And those latter two aren't going to get better by just non-surgical means. If it's a relatively small lesion, then surgically, you just take it out and do something to the base to try and get the cartilage to defect to fill in. It fills in with fibrocartilage. It doesn't fill in with hyaline cartilage. If you have a very large osteochondral lesion, then there are more advanced methods of trying to fill that in. Everything from squirting some gel on it that replaces cartilage all the way through to actually using cartilage from the knee, osteochondral transfer. Obviously, that's a lot more invasive, but I'll just show you some pictures. So this is an osteochondral lesion of the lateral talus. So that's the fibula at the back. Here's the syndesmosis, tibia at the top, talus. So there's this big sort of funny area here that clearly doesn't look normal. And so at the time of surgery, you actually remove that and you get back down to the bleeding bone underneath it. And the aim is that that bone will then send some sort of reparative material up to fill in that defect. Again, here's another one, this little probe at the end here, that's about 1 millimeter in diameter, just to reference for you. But again, you can see this is clearly an unstable lesion of the talus. And again, there's my little shaver, that's 3 millimeters in diameter. And so we remove the loose cartilage because it's dead. It's not going to recover. It looks really sad that you've taken this cartilage off, but that cartilage is dead. It can't be repaired. And you want to get down to this layer of the bone here. And I'll actually go to the next one. Here's another one. That's a real blob of cartilage loose. You take it off, and this is a microfracture. So those of you who've done knees, you may have seen people do microfracture in the knee. It used to be very trendy. It's not quite so trendy. But the end on that's about 1 millimeter in diameter, and the whole aim of it is to push little bone holes into the cartilage, or sorry, into that hard bone under the cartilage. And you can see here there's a bit of blood that's coming out. And the aim is that your maybe stem cells, multi-potential cells, are going to come through this, sit in the blood clot that forms on the top of it, and hopefully grow some chondral tissue. As I said, it's going to be fibrocartilage. It's not going to be hyaline cartilage. So that's what microfracture is. But if we go back a couple, if you want to spend $6,000, you can squirt some stuff onto it that's supposed to improve cartilage regrowth. So that's the defect. This is a little cannula. That's again about 1 millimeter in diameter. And this sort of slime stuff that's here, this is a material that is a bit like glucosamine in that it's like a scaffold for cartilage. It's not actually cartilage. It's not got any living cells in it, but the aim is it's this little area of gel that sits on top of the defect that then sets and hopefully allows the cells that are coming in from below, from those little holes you've drilled, to sit in the defect and form some cartilage quicker. Has anyone seen that done in the knee or anywhere like that?
Yep. Sure have. I've seen it done the ankle. And I was going to ask you the question. Does studies show if you're paying $6,000 that it increases the likelihood of better cartilage compared to straight microfracture?
Yeah, there is a study that definitely shows that. The problem is that as of about 2 months ago, all health funds in Australia decided that that wasn't good enough evidence to justify the $6,000. So it's been removed from the market. Well, it's available, but it's not paid for by your health insurance. But there's a blinded randomized controlled trial currently going on in several places, which will hopefully prove that it does make a difference. This is a recurring issue with these advanced treatments of cartilage damage. There may be someone in the audience who remembers MACI or ACI, autologous chondrocyte transplant. That's where we took a bit of cartilage, sent it off to Perth. They grew it up in the laboratory for 6 weeks, sent it back to you with all these little chondrocytes inside this little patch. And then you went back into whatever joint it was, whether it was the ankle or the knee or potentially the shoulder, and you put this little patch of material on the osteochondral defect, and you actually were delivering live cells to that area. And that was supposed to theoretically give you hyaline-like cartilage, but that was costing about $20,000. And so that got killed off about 12 years ago because the evidence, again, wasn't great. The other alternative is to open up the ankle very aggressively and take cartilage plugs from the knee and stick those into the ankle. That's clearly a much more invasive and at the donor site anyway. That's called osteochondral transfer or mosaicplasty. Has anyone heard of that one in the knee? People moving cartilage from the tibial trochlea down to bits of the knee. Has anyone seen that before?
Yes.
Okay, so there are all these other advanced ways of trying to fill cartilage defects. Clearly, those are only done when either the defect is huge or other types of treatment have failed. Long and the short of it, I think what you need to know as a sports team, as a sports doc, is that osteochondral lesions can be a cause of ongoing pain on a normal X-ray. and if they're loose and or a lot of edema underneath them, if they're not getting better over a number of months, then it is probably worth doing something about them surgically. Surgery has an 86, or I will also use the number 85% chance of making a significant difference to pain at the end of 3 months. But speaking about what you were talking about, recovery time, if you do a significant osteochondral microfracture, so this sort of stuff here, as I said, that little canyon is only 1 millimeter in size, so that entire defect is about 12 to 15 millimeters long. But you do not want this person doing impact activities for 3 months. You want them ranging the ankle, you want them, working on their proprioception, but you do not want them impacting through that ankle. So this is certainly something that puts someone out for a while.
Right.
Questions or thoughts, anybody?
Ben, so if we saw a patient, footballer, has an ankle sprain, MRI shows medial talar chondral fissuring.
Yep.
So in my mind, that's like, a little bit of the cartilage has been scratched, but
Yep.
we don't have a big defect, and
Yep.
you're not going to see the fluid signal. In terms of that, if they go 6 weeks and they're still struggling with pain.
Yep. I guess the question is where they're getting their pain from. It could be ankle synovitis. It could be deltoid injury. It could be posterior medial synovitis. It could be from their talus. But if there's not a lot of edema on an MR, then it's probably not symptomatic.
Yeah.
Because cartilage has no nerve supply.
Mm-hmm.
When you get pain from an osteochondral lesion, there are 2 proposed thoughts. One is there's synovitis around it in the joint, and the second is that there is edema and irritation of the underlying bone, which does have nerves. So if there is very little edema in the underlying talus, then it's probably likely to be synovitis.
Mm-hmm.
That's the sort of patient that usually does not need to be rushed into an arthroscopy on the basis of that cartilage lesion. Now, the question is, should you be MRIing people at day 1 or day 5, or should you be using your clinical judgment to see how they're getting on and maybe MRing them at 6 weeks if they're not improving? That's a philosophical issue that you guys need to individually work out. I can tell you that early MRI scan does over-diagnose the extent of injury. A lot of that swelling that you see on an MRI early is not actually relevant to their condition. The things that MRI early does show, which are very useful, is doing a syndesmosis. And it does give an idea about bone bruising. So if you see a whole lot of edema in the talus, that's because they've had a bone bruise, then that's prognostic. You can tell that patient that ankle is going to probably take a lot longer to heal than the ankle that has no bone bruising. But MRI overcalls ligament injuries. It overcalls tendon injuries early on because there's just too much edema for the MR tech or the MR radiologist or the surgeon to actually work out what is true and what is actually artifact. So just to let you know that there's a good study about 8 years ago that showed that examining someone's ankle at 5 days will give you just as much information on their ligaments than MRIing them. So I personally see a lot of early MRIs because sporting clubs tend to get them. As I said, the only thing I really take out of an MRI early is what's happened to the syndesmosis.
Yeah, it's interesting, Ben, because that's exactly what happens, because there's a lot of pressure on club doctors at elite level to get an MRI, know exactly what's going on straight away in patients. And and often it doesn't change the management unless it's syndesmosis injury. But there's a lot of pushback to not ordering an MRI. So it's a really stupid situation. And half the time they ignore the findings anyway. So
correct. But I guess I am not a hamstrings doctor, but I presume you do a fair few scans of hammies and of abdominal wall, chest wall injuries. And it just gives you a degree of confidence about how serious that soft tissue injury is. And it does have prognostic value, and it does, it's a 2-week injury rather than a 6-week injury. So I do understand why they're done. It's a safe investigation. It's not like you're doing CT or bone scans. You're not actually harming somebody by giving them an MRI. So I don't have a major issue with them being done, just understanding that they're not the whole answer. You as a doctor, me as a doctor, and as a physiotherapist, we can make very good clinical assessments without having an MRI. I don't know whether any of you remember, but there was a NBA basketballer who did his ACL very obviously, and he went down, this is in the US about 2 or 3 years ago, and he went down to the rooms, the sports doc examined him, and he clearly had a Lockman, he was gone. And they reported that during the game, and some of the commentators were going completely nuts about how this doctor could diagnose this man's ACL injury without an MRI scan. And the reason, of course, is that sports doc knowed this guy's knee intimately well before this injury, and what was a stable knee now has a grade 3 Lockman and a hemarthrosis. You don't need to be an MRI to prove that diagnosis. But as I said, these media commentators on ESPN were going off their tree about how amazing this doctor was, or thought he was, because he could diagnose an ACL tear. But that's the sort of stuff that you've got to obviously have in the background. I was speaking to Tex Walker a few years ago, and he was telling me that there's 2,000 journalists currently covering the AFL. And all of those people need to get a scoop or a story. So they're going to come up with anything. And you just need to be aware that there are many more people outside of an elite athlete than just the elite athlete and you. Going on to the syndesmosis, let's just cover that one, because this is definitely a useful thing for arthroscopy.
Ben, can I ask a quick question?
Yeah.
With that bone marrow edema in the talus, how long do you generally say that takes to settle down from a pain perspective?
Yeah, that's really important what you said at the end there, okay? There's symptoms, and then there's MR. On MR, it can take 6 to 12 months for a serious bit of bone edema to really resolve. Symptom-wise, it usually takes around 3 months, but that can be a cause of ongoing pain for 6 months.
Right.
So in someone who has ongoing pain that I get referred to, me, who had early bone edema, a lot of it, basically they smash their talus, usually the medial talus into the medial malleolus. They're the people that I will often rescan at 6 months to see whether or not that edema has gone. Because if the edema is improving or gone, then their ongoing pain may be due to something else, like a deltoid injury, a POMI lesion, some inflammation and scarring at the back of the deltoid. It may not anymore be their talar bone edema. But it definitely can take anywhere from 4 to 6 months for that symptom to go. And it's a weird symptom. It's often sort of an ache. It's sort of non-specific, activity related. Ankle moves well, ankle feels stable, but they just have pain. And what you do about it is usually diagnose it and reassure, make sure they keep rehabbing their ankle. There are some weird and wacky treatments that you as sports doctors may or may not want to use, things like Forteo and Pentasan and other sort of experimental treatments. I can't give any advice on that, but I know some people are getting given those.
Great, that's really useful. I don't know what Forteo is though, I've never heard of that.
Forteo's, if you read the Forteo syringe, it says this will give you osteosarcoma if you're a rat.
Parathyroid hormone.
Yes, so we're talking about tetraparathyroid hormone, synthetic parathyroid hormone. So there are people using those sort of off-label indications for these medications. Again, you need to speak to an expert in that field. I'm not going to give you advice on that one.
Thanks, that's really useful.
Okay. When we talk about syndesmotic injuries, it's pretty simple. They're either stable or they're unstable. The hard bit is working out what's unstable and what's stable. It is obvious in some people that they have a significant syndesmotic injury. Their x-rays show that their tibia and fibula are not anywhere near where they should be. That is very obvious. That is an acute, severe injury. There are also people who have an MR or an ultrasound which shows a little bit of edema and swelling in the AITFL. That is a syndesmotic injury, but it is a stable injury that is extremely common. Up to 20% of regular ankle inversion injuries have some degree of anterior syndesmotic injury. And that is certainly something that needs nothing more, but it might take an extra couple of weeks to rehab. Then you have this group in the middle who've had an ankle sprain that's just not getting better, and they have an MRI or an ultrasound, which reports a complete tear of the anterior syndesmosis. And that's the group that are potentially unstable. Karthik, what things hold your distal tibiofibular joint together? What are the components that hold your syndesmosis together?
The anterior syndesmosis, so AITFL, interosseous membrane, and the posterior inferior tibiofibular ligament. Excellent.
That's the syndesmosis. And the other structure that you always need to take into account is the deltoid ligament, because the deltoid is keeping your talus medially relative to your medial malleolus. So if you have a complete deltoid tear, you don't have anything on the medial side holding the talus medially. So if you have any syndesmotic injury, then that makes the syndesmosis even more unstable. Does that make sense? If you've got a syndesmotic injury and your deltoid's still intact, your talus isn't going to shift over. But if you've done both your deltoid and your syndesmosis, then it's very unstable. So there are different classifications or diagnostic criteria, we'll call them, based on MRI. But if someone has done their anterior syndesmosis, their deltoid ligament, and their posterior syndesmosis, they're about 96% likely to be unstable. Okay, so you can actually call someone's syndesmosis unstable on an MRI. However, I get to see a lot of people who've had a minor deltoid injury who've completely torn their anterior syndesmosis and have a bit of edema in their posterior syndesmosis. And that's the group where you're not quite sure what the situation is. So in my hands, there's 3 ways of managing that patient. If you really don't need to know straight away, you can just see what happens. If they're getting better over the next 3 to 4 weeks, then that's great. They're walking around, they're getting comfortable, they're able to hop and jump, then that's a stable injury. If you know that, if you need to know now what's happening, then there are 2 ways of going. The most accurate method, but invasive method, is to put a telescope into someone's ankle, because you can really accurately assess how unstable their syndesmosis is and or fix it at the same time. The other technique which I tend to use for syndesmotic injuries that I don't know is the weight-bearing CT scan. There is some evidence to show that scan does have correlation between instability and not instability. Have everybody online actually seen a weight-bearing CT scan for a syndesmotic injury?
Yeah.
Yep.
Okay, what they do is in different positions of loading, usually squatting forward, what they call the shush position, they assess, comparing both sides, what the gap between the tibia and the fibula is at a centimetre above the ankle joint. And if it's more than 15% up, then that is an unstable syndesmosis. Some people say if it's more than 10%, it's unstable. My cutoff is around 15. I had a patient on Monday who, when he doesn't stand, both his syndesmotic areas are exactly the same. And as soon as he stands up, one of them increased by 20%. Okay, so that's pretty obvious that on the background of a recent ankle injury and an MRI showing a syndesmotic injury, that's an unstable syndesmotic injury. Every now and again, you get someone who you don't think their MRI should be unstable and they do a weight-bearing CT and they're unstable. And there are people who have a syndesmotic injury on MRI and you do a weight-bearing CT and they're not very unstable. So it is a way of trying to, I guess, bring a bit of science perhaps into an area that's difficult to assess. It is radiation. It is expensive. If someone's had an X-ray, potentially an ultrasound, an MRI, and then a weight-bearing CT, that is a lot of diagnostic cost to that person. So it's a bit tricky. Again, I'm not going to give you your protocol for syndesmotic injuries. You need to work it out. I would say that not every syndesmotic injury needs an operation. It's a really important take-home point. And before the advent of easily accessible MRI, there were huge numbers of syndesmotic injuries out there, these anterior syndesmotic injuries that were just the ankle sprain that just took a bit longer to get better. Again, I'm going to leave it up to you what your particular management plan for a syndesmotic injury is. If I get sent somebody and I'm worried that they're unstable, they will usually get an arthroscopy. At the time of arthroscopy, there is the syndesmosis here. So that's fibula, that's anterior distal tibia, this is talus, and that there is the syndesmosis. So the anterior syndesmotic ligament, AITFL, would normally go across this area here. I shall go to this one here. This is what a ruptured anterior inferior talofibular ligament looks like. And if you look behind it, there's a big black void, which is where the tibia and the fibula are definitely dissociated. This is the talus down here. And I'll show you this video. Okay, so this is tibia, this is fibula, that's talus down the bottom there. So you can see with an external rotation test that the syndesmosis just opens wide open, okay? Remembering this is magnified. So what we do is we quantify how much instability there is by using our little probe. Technically, if there's more than 3 millimeters of instability, that is unstable. But again, when you see something that goes that, clearly that's not good. You could basically look all the way up that patient into their knee almost, straight up their interosseous ligament. Again, here's an unstable syndesmosis. There's tibia, talus, fibula. That's my little probe here, and you can see this big gap here. So that person's front and back syndesmosis have completely torn. Questions about that? It's a big topic, syndesmotic injury.
Ben, with if you got someone that comes in clinic, they have an acute injury, you got pain with external rotation, tender over the ARTFL, squeeze test induces pain over that region. You do your weight bearing plane films on the Saturday. They don't show any widening.
Yep.
You are going to send them for an MRI. Will you allow weight bearing in the boot, or will you say non-weight bearing until we get the scan? I've heard two schools of thought. Some allow it and some don't.
If your weight-bearing x-rays show no fracture and there's no diastasis of the syndesmosis, then them putting a little bit of weight through that is not going to cause any problem at all. It's the person who hasn't had an X-ray, who gets put in a boot and then told to just walk around on it, who's had a significant ankle injury. They're the ones you just need to be a bit cautious of, because they've not actually had the basics of an X-ray just to rule out fracture or significant other injury. I don't have a problem with someone walking around, but if they've got a planned investigation, you just want to tell them not to do too much before they get that scan, because it's probably not going to change their management. It's still worth giving them some crutches, but I think it's actually functionally quite useful to put some weight through a leg. You certainly don't want them jogging around on it, though.
Sure. So you're just going to partial weight there with crutches, really?
Yeah, correct. Okay, and manage their swelling. Rest, ice, compression, elevation. If they've got a really swollen, sore ankle, then they need to be doing that anyway. As you guys have probably seen, though, there are some people who tear their anterior or their syndesmosis, and they have very little swelling and very little bruising. It's because over the syndesmosis, there aren't any major veins, which means you don't tear those veins when you severely injure your syndesmosis. When you invert your ankle and you tear your ATFL, there are lots of veins over those, and that's why people go purple and really bruised early after a regular ankle sprain, is because they actually tear veins around their ankle. But that doesn't exist at the syndesmosis. So you can get, if you classify injury severity based on swelling and bruising, you can definitely miss the syndesmotic injury.
That's really useful. Can I take it one step further? You did a case for me, one of the North players, and you did a scope and did a probe, and it was greater than 3 millimeters. And then you did an open procedure and put an AITFL brace. Yep. Could you just speak to why you do it open and what that is, and if you have any pictures or something? I just was interested.
If you have an acute syndesmotic injury and the MRI scan and your arthroscopy shows that the posterior elements are intact, your options for surgically stabilizing that are to use some sort of suture button, and that's what you guys would know as a tightrope. But you can also do a primary reinforcement of the AITFL with a bit of stitch. The benefit of doing the stitch over the AITFL is that you don't have a tightrope in someone's leg for the rest of their life. About 1 in 20 tightropes need to come out. The downside of doing a primary open AITFL repair reinforcement is that it is an open procedure. It's a 3 centimetre incision. There is a slight risk of nerve injury, but it doesn't ever have to come out again. So it's basically a piece of string that goes across the AITFL. You usually can't repair the AITFL because it's been shredded. But you put this piece of string across it, which sort of supports the anterior syndesmosis, so it can't open up with external rotation, and then the ligament heals itself just fine. So it's dealer's choice. I will tend to do we'll call it a tightrope in most injuries, because in most injuries I know that their posterior syndesmosis is also unstable. But you've got to remember, the aim of these sort of surgical procedures is just to put the syndesmosis in its normal position so it doesn't widen with movement of the ankle, and then ligaments heal by themselves. If you have got somebody who's 3 months out from a syndesmotic injury and they've got a lot of scar tissue in their syndesmosis, you do need to open that syndesmosis to get the scar tissue out, adequately reduce the syndesmosis, and then hold it there. In that situation, given you've already made a cut to get into the syndesmosis, you might as well put the little bit of stitch material across it rather than, again, putting a tightrope across. This is outside of today's talk, but if it's, say, 6 months or a year after a syndesmotic injury and they've got a very unstable syndesmosis still, that person's going to need some sort of hamstrings reconstruction. And again, they're going to need an open procedure. But again, we're not going to be talking about that one today. Take-home message is it's dealer's choice. There are some people in Melbourne who are putting both a tightrope across and an internal brace across the front of the AITFL. But there isn't any evidence to support that. But again, what happens in an AFL club in Melbourne often percolates through to other people, because clearly what's done at one AFL club needs to be done by everybody. The fact it was experimental surgery with no evidence behind it may or may not be something you want to do.
Right. Yep. And can you do it arthroscopically, some of that stuff? And does that give you a fast return to play but lesser outcomes, or?
You cannot put the band across the syndesmosis arthroscopically. It needs an open cut. You can put the tightrope across with only a little baby cut. At the end of the day, though, I tell my patients that their return to sport is dependent more on their injury than on my surgery. In other words, my surgery is going to slow them down for a week or two because they've got a cut in their leg that needs to heal. But their syndesmosis is actually more stable after my surgery than what it was before the surgery, which means that it's not my surgery that's going to determine their return to sport time. It's how their leg heals and their rehab.
Is this why, Ben, you see players in the AFL kind of come back after the syndesmosis injury, 4 weeks? I guess they're meeting all their rehab guidelines and.
Correct. Here's an interesting question, Karthik. Do you think that patient actually needed an operation in the first place?
Yeah, well, this is the thing. We don't know. Was it just the anterior syndesmosis that was gone and was going to heal by itself?
There's a lot of people having surgery on syndesmotic injuries that don't need it. However, none of us have a crystal ball, and there is sometimes an expectation, well, syndesmotic injury equals surgery, and then we have a reliable and potentially accelerated rehab program. If we all could go forward 6 weeks in time and look backwards, it'd be very useful. But I can guarantee you that there are patients that I have put a syndesmotic fixation in where it was questionable whether they were actually going to need it, but I was told I needed to do it because that was what was expected. And then I'm very happy to say, well, as long as you don't get a complication, once your wounds are healed, you can go as hard as you like. There's another side to that discussion about putting the telescope into someone's ankle to prove their ankle is unstable. I have a number of patients, one of the LA United guys particularly, who we were not sure whether they were stable or unstable. And so I put the arthroscope in and we assessed that he was actually stable. He'd had a syndesmotic injury, but it was stable. And we did not put any fixation into it. We cleaned out his ankle. And then when we woke him up, we basically said, well, you've got a syndesmotic injury, but it's stable. This was 2 weeks down the track from his injury. And basically, as soon as his wounds were healed, we said, go for it. And he definitely got back to sport earlier than he would have if someone was following a conservative protocol for a syndesmosis, because we'd proven that it was stable. And psychologically, that helped this guy, but it also meant that there was, a bit of ache and soreness. No one was freaking out about it. They just sort of pushed him through it, and it got better, quicker. So that's just the other side of it. There is the option that you go in there and you don't have to do anything, but that is uncommon. I don't like operating on people unless there's a good chance I actually need to fix them. But it is fairly minimally invasive. You're unlikely to give someone a problem, but there are people who've had infections after ankle arthroscopy. There are people who've had blood clots after ankle arthroscopy, and there's about a 1 in 160,000 chance of getting a really bad problem under an anaesthetic having an arthroscopy. So you do need to balance up those risks. Now, other things I was going to try and look at. Let's have a look here. Where's that gone again? Here we go.
Sorry, Ben. I've got a patient I've got to go, but thank you very much.
Yeah, no problem. I know I'm pretty much finished. I was just going to show this for anyone who's still on there. I'm just going to show because I got to go too. You can stick the telescope into different places. This is the perineal tendons. This is what the perineal tendons look like in normal situation. Okay, so that's the brevis tendon, that sort of curvy thing on the side. The big one at the bottom is the more spherical, more cylindrical, longest tendon. So that's what tendons look like if you look at the assessment of them. That thing across the top there was the superior retinaculum that keeps them stable. Okay, so you get quite a good look up the perineal tendons. So they're completely normal. That's what a happy tendon looks like.
And when do you do that diagnostically? Is that for chronic synovitis that's just not settling with conservative management, or partial tears that need fixation, or?
It's when someone's got a bit of pain over their perineal tendons and the MRI or the ultrasound, or it's not quite clear what's going on. Because you can also see this. So this is someone who has, this is peroneus brevis. We're coming over the back of it now. Down we go, and that's a split tear. Okay, that thing at the bottom there that now is opening up, you can see that's a tear in that tendon. That'd be pretty hard to diagnose on ultrasound. You might see on an MRI. So again, someone where you're not quite sure what the what that diagnosis is. That's a pretty easy thing to do. Now again, going back to this one again.
And you just stitch that together?
If you find one of those, you need to open it up and run some stitches up it. That's correct. Other things you can do with the telescope, you can look in the sinus tarsi. So that's an ankle arthroscopy portal. That's two sinus tarsi arthroscopy portals. That's an ankle stabilization scar. And again, that's me looking in the side of the foot. And you can see stuff. This is the interosseous ligament between the talus and the calcaneus, and that can be torn and degenerate. And you can get a good look at the subtalar joint here as well. Perineal tendons come over here. So you can do things, clean out synovitis, remove partially torn interosseous ligaments for so-called sinus tarsi syndrome. We're running out of time. Any particular questions I can help with?
No, I'm fine.
That's been really good, Ben. Thanks.
I'm just going to go back to that one, I think. Cool, awesome. If something changes, if some questions come up, please let me know. But otherwise, good luck for the rest of the year, hey?
Thanks,
Thanks,
Ben.
Ben.
That was terrific.
Right, thanks, Ben. Appreciate it.
Okay. See you, everybody.
Bye.
Bye.